Welcome to Need to Know, part of our Grand Rounds in Urology series. I've had the privilege of being involved in clinical trial development and execution for over 3 decades. In clinical research, we rely on a variety of parameters to determine significance. We're all familiar with things like p-values and hazard ratios and so forth, and designing phase 3 trials and even phase 2. Unfortunately, within urology, we've lagged behind other specialties in incorporating molecular markers into both diagnosis and treatment planning. It's beginning to change. Joining me today to discuss a critical framework for assessing the significance of molecular markers is Dr. Stephen Stone. He's a distinguished expert in this area of molecular diagnostics. Rather, he has held major leadership roles in R&D with Myriad, where I first met Steve a long time ago, CareDx, Demtech, and now in Envision Sciences. He has a particular interest in trial design and outcomes, and today I've asked him to talk about an important tool that's out there in the spotlight right now, something called Simon criteria. This is a framework used to evaluate the clinical utility of biomarkers. Steve, thanks for joining us to share your thoughts on this.
Dr. Crawford, thank you for the invitation. I actually am very excited to come here because I also have thought a lot about, how best to validate biomarkers. I mean, as you just said, I've been in the field for a long time. And this sort of the accession of the Simon criteria as a gold standard for evaluating biomarkers is obviously important to me. And I was trying to understand, what's its relevance and how important it should it be. And so appreciate the opportunity to come and talk about it today. So the Simon criteria for biomarkers, it's really all based on this paper that came out in 2009 from, Simon et al. About how to evaluate prognostic and predictive biomarkers. And what they say very clearly in there is that a fully prospective randomized clinical trial to evaluate the medical utility of prognostic or predictive markers are the gold standard. And so the question in my mind started to become, well, why is that true? What is the value really of randomization and prospective design to the validation of a prognostic marker? And so on the next slide, I sort of, in my mind at least, have outlined what I think the value of an RCT is. When you randomize patients, like for 2 arms in a clinical trial, the assumption is that the overall risk for disease progression is balanced between the arms. And because you've randomized, it's, unknown and known factors can be adjusted for. And so in that context, any difference in outcome between the 2 arms overall, can be attributed to the impact of treatment. And so for a drug trial, clearly a randomized clinical trial is key. And it has to be prospective because it's a new drug. So I've shown a Kaplan-Meier here of a drug trial where we've randomized between 2 arms. The blue arm hopefully being the new drug, the green arm being the standard of care or some old drug. And any benefit there, as shown here, can clearly be attributed to the drug. So that's clearly important. I think it's also really important to use RCTs to make predictive claims. So on the right of this slide, I've shown a cartoon of how you expect a predictive marker to behave. A predictive marker, what that really means, what you're really saying is I have a marker that identifies men that are in prostate cancer men, who are likely to respond or not respond to a particular drug. And in the classic case, what you want to show is in the treatment arm, in the drug where you're claiming a predictive effect, say the men that are biomarker plus compared to the men that are biomarker negative, they have different outcomes. And that difference can be attributed to the biomarker plus group being more likely to respond to the drug. Well, how do you know, though, that it's not just a prognostic effect? You know that by then comparing the Kaplan-Meier in the treatment arm to the Kaplan-Meier in the control arm. In this case, what you'd expect is that the biomarker has no impact on outcome because, you're making a very specific claim that it's predictive, that the biomarker predicts response to the drug in the treatment arm. So if that drug's not in the control arm, the 2 groups of patients should perform identically. And of course, there's no way to show that rigorously without in any other context but an RCT. But what about a prognostic biomarker? So here's the thing, like I'm confused. Like I don't fully appreciate, I guess, what the value of randomization is for a prognostic biomarker. So in an RCT, we have a treatment arm and a control arm. How do we expect our prognostic biomarker to behave? It should, if it's a valid prognostic marker, stratify risk in both arms. Now, in the treatment arm, if the drug's successful, the overall risk may, for both groups, be reduced, but the hazard ratio should be the same in the treatment arm and the control arm between the biomarker positive group and the negative group. Okay, and that is the sort of the signature of a prognostic biomarker. What if I take that same marker and apply it to a really real world clinical series? I see the same Kaplan-Meier. My prognostic marker stratifies risk, just like it did in the RCT. So in both cases, I would say you have validated your prognostic marker. Now, are they equivalent? Actually, I don't think so, because in the RCT population example, the patient population and the subsequent treatment is likely to be narrowly defined to fit the aims of the RCT. But ideally, you would like your prognostic test to stratify risk regardless of the clinical risk factors of your patients or the subsequent treatment decisions. I mean, that is, in fact, how you use a prognostic marker. So I would argue actually, given that the study was well designed, that the validation is more important in the real world clinical series. Now, what are important design elements for a prognostic marker? Well, the tissue collection is very critical. That should be prospective. Otherwise, you do run a risk of introducing a bias in your patient population if you have to go back sort of and retrospectively collect samples. So that is important. That is an important piece of any validation of a prognostic biomarker, but it doesn't have to be within the context of an RCT. A prospective patient collection in a real world clinical series, to me, is equivalent. And then, of course, endpoints are really important. Like, because, you're in the actual idea of a prognostic marker is to identify aggressive disease. So you want your endpoint to be clearly and well accepted surrogate for what aggressive disease look like metastatic disease or disease-specific mortality. Or it can be some, shorter term event like adverse pathology, of course, as well. But something that everybody agrees is really indicative of aggressive disease. So to me, those are the important factors. And that's it, I think. Thank you very much.
Thank you. I know there's a lot of issues right now with how you evaluate markers, and I think you kind of put it into the framework that we need to talk about. Randomized clinical trials are have been the way of the past, I think, in a lot of things, and we've certainly done a lot of them that I've seen in my career. Now it's, as you well know, it's all about data, and we're seeing a lot of things. When you have such large databases, you can start making decisions. Let me just let's Simon criteria. So, what criteria should we use to evaluate prognostic markers, if not this?
Yeah, it's a good question. I think, unfortunately, getting your test into clinical guidelines is a huge sort of barrier for both payer adoption and clinical adoption for test developers. So that decision becomes really important. And I'm afraid there is no simple predefined cookie cutter criteria that I think should be employed. I think the guideline committees should carefully evaluate all the evidence that a test developer brings to the table, just like the FDA does, and make a decision based on the totality of that evidence. And so if they have several real world clinical series that are well designed with pre-specified statistical analysis plans and prospective patient tissue collection, that evidence should be considered sufficient for guideline inclusion. But I'm afraid it just has to be, evaluated case by case with experts in the field who can identify study designs that are likely to introduce bias and then exclude those from guidelines.
Why have so many committees, guidelines adopt that Simon principle here?
Yeah, well, I don't think it's so many. I mean, I think that the prostate cancer NCCN committee is a little bit of an outlier in terms of Simon adopting Simon, but many people do like it. And I think the issue is that people are worried about bias. And so they think, well, the simplest way to avoid bias is randomization. But as I've just explained, I don't think that in this case, an RCT is the kind of bias that you're worried about. What you're worried about is bias in the patient population for which you're testing. And if you do a clinical observational series, like from let's say 2010 to 2015, and you take all comers and you collect those patients prospectively, I don't think bias is a significant concern.
One last question here. We're running out of time, but is there a role for randomized clinical trials for developing and evaluating prognostic markers today?
I think there is. I think there is in terms of evaluating like the final impact on patient care and outcome. Of course, that has to be done prospectively, but you would create a trial where you randomize like almost a 3-arm trial where you first randomize to a arm that's not going to use a biomarker and a second one that is. And then in the arm that's using the biomarker, you would stratify risk, identify high-risk patients and low-risk patients. And then for the high-risk patients, intensify intervention. For the low-risk patients, de-intensify intervention. And show that not only maybe that you improved outcomes, like in terms of disease outcomes, but that like the cost per patient episode is less and morbidities are reduced. And I think that's really the value of a prognostic of improved risk stratification, is reducing the amount of unnecessary morbidity due to treatment.
Steve, thanks very much for your time. You've really shed some light on this area.
Thank you very much. I appreciate it.